Okay, all right. We are back for the next episode of the WashU Nephrology Renal Path series. We are here with a case discussion. I'm pleased to welcome Dr. Joe Gaut, again, our section head of Nephrology, and Karthik, one of our second-year fellows. Thanks for joining us, guys. Let's start right off with the case. It's a little bit more in-depth than before. This is an 81-year-old Caucasian male with a past medical history of arrhythmogenic cardiomyopathy, status post-ICD placement, hypertension, hyperlipidemia, who comes in with a month of worsening shortness of breath. That's his chief complaint. He had a productive cough with white mucus, and he actually already received 2 courses of oral antibiotics, which were azithromycin and levofloxacin for bronchitis, which did not lead to significant improvement. And also before arrival, he has noted decreased urine output, dark colored urine, and worsening edema over the past week. And he's gained 10 pounds over this time. So when he comes to the ER, he's actually quite hypertensive to 180, and his labs show, as you can see here, his creatinine is up to 1.5. His baseline was actually 1 6 months earlier. His urine sediment shows protein and blood. His urine sediment was spun and actually showed multiple dysmorphic RBCs and an RBC cast. His chest x-ray showed mild atelectasis, and a non-contrast chest CT showed multifocal ground glass opacities consistent with an atypical pneumonia. So actually this case came in on a Thursday evening, and so Karthik, before we kind of move on, let me ask you, if you were the fellow seeing this patient in ER, what would be your initial thoughts and how would you proceed from here on out?
So this is an elderly gentleman who is presenting with acute kidney injury in the setting of a recent infection. He has had an extensive cardiac history. So my initial thoughts, it's an oliguric acute kidney injury, common things being common. He could have acute tubular necrosis from the recent infection. But given the fact that his urine sediment shows dysmorphic RBCs and a red cell cast, the chances of a glomerulonephritis is high. In this elderly age group, I would think more in terms of vasculitis-like picture.
Great, okay.
He's been hypertensive for many years too, so hypertension can also cause this kind of picture, but dysmorphic RBCs is not a common finding. Lupus can present in this fashion, but he's not African American, is not a young female, but it would still be on differential.
Sure. Yeah, a little unusual for lupus, but you mentioned the big one, the vasculitis. Also, these vague pulmonary
renal syndromes can also present like this.
And I guess the other thing I would add on to that would be like anti-GBM disease, again with the pulmonary renal nephritic pictures. But I think that's a really good differential, and that's exactly what we were thinking. He got some preliminary workup. They swabbed him for virals, which were negative. We did quantify his urine, which was subnephrotic at 530 milligrams in a day. The only positive thing in the workup was a mildly low C3. It was 68. And his serologies for infections and autoimmune diseases were negative. And this is kind of the course of what occurs. So he comes in on day 1 with a creatinine of 1.5. By the next day, his creatinine's already up to 2.
Okay.
And we, because of the nephritic sediment, because it was a Thursday/Friday weekend coming up, we wanted to do the biopsy quickly. So we actually did the biopsy within 24 hours of presentation. But you can see that even after the biopsy was done, his creatinine kind of took off. So we're going to jump to the histology now. I'm going to let Joe take it away. You should have control of the mouse.
All right, great. All right, Karthik.
So
what are we looking at?
There are 2 cores of kidney tissue, and it is Trichrome stain.
Trichrome stain.
So I would be looking at chronicity to see if there is fibrosis that would look blue in the trichrome. I don't see much of it. It's more pink. Could see quite a few gloms on the core.
Yep, there's plenty of glomeruli here. We have a nice couple of pieces of predominantly cortex, and yes, the main reason to look at this low power is to just look for some sign of chronicity, which would be increased interstitial fibrosis, which would be a dark blue color on the trichrome stain. We really don't see much, which goes along with this being somewhat of an acute clinical presentation.
Right.
Okay. So what stain is this?
H&E stain.
Yep.
And looking at the tubular interstitium and one glom in the 8 o'clock position. I don't, the tubules are back to back. I don't see much of interstitial inflammation.
Right.
There are dark red staining material in the middle. I'm not sure if it's a vessel with a thrombus in it.
This is a tubule.
Okay. It's a tubule with a red cell cast.
And a red cell cast right here. So that's what this is showing, which goes along with what you all saw on the urine microscopy. So we do have scattered rare red cell casts in some of the tubular lumens. Yeah, we'll look more closely at the glomeruli here in just a minute. But you don't see much in the way of interstitial fibrosis. There's no white blood cell casts. There's really no significant interstitial inflammation either. Okay.
Right. Okay.
Now, so one other thing we can kind of point out here that we do see, you see some of these tubules have these kind of collections of nuclei, these little nuclear knots. That does happen with acute tubular injury.
Okay.
And some of these tubules do have some cytoplasmic blubbing, but it certainly doesn't look like any widespread ATN where there's coagulative type necrosis all over the place. You can make out the nuclei in all of these. There's not terribly significant luminal dilatation of the tubules. So there probably is a component of acute tubular injury, but it doesn't look like there was a large infarct or something else that might have occurred. Okay, moving on.
Okay.
All right, so what stain are we looking at here?
So PAS stain.
Very good.
Looking at the glomerulus and the tubules. The glomerular basement membrane thickness, I would like to compare it with the near tubule to see if it's more thick or not.
So let's start while we're looking at this. Let's think back to your differential.
Okay.
Okay. So you had vasculitis on the differential. What were some of the other things you had lupus on the differential, very low. Hypertensive disease, ATN. Was there something else I'm forgetting?
Anti-GBM.
Anti-GBM. Okay. So in the ANCA vasculitis or anti-GBM vasculitis, what would we expect to see in the glomerulus?
So there'll be inflammatory cells in the glomerulus. The basement membrane would appear thickened.
Well, now what would we expect to see right out here in Bowman space? In those cases, most commonly in ANCA, in a vasculitis and anti-GBM disease, you would see what out here? Cells proliferating out here in Bowman space. You'd see breaks in the capillary loops. And what do we call this?
The cauliflower-like appearance.
Well, I'm talking about if this were. I'm not talking about what this looks like, but if it were ANCA, if it were a vasculitis or anti-GBM glomerulonephritis, and I'm describing what I would expect to see. I'd expect to see a lot of cells out here in Bowman space.
Right, okay.
And you would see breaks in the capillary loops. You would see inflammatory cells as well.
Right.
So those would be crescents. We're basically I'm leading the witness here to say crescents is what you would normally expect to see in a case of ANCA-associated vasculitis, anti-GBM disease.
Right.
All right? Now here, we don't see that.
Right.
All right? Now, not to say that it couldn't be somewhere else. Another thing that you can see in those instances is focal necrotizing glomerulonephritis, and we don't see that either, just focal necrosis of the tuft, which can be very difficult to find sometimes. So, going back to what we have here. So we do have something else. You mentioned there's cells. And where are all the extra cells?
It's more within the capillary loops.
Yeah, there's too many cells within the capillary loops.
And they appear closed.
And they appear closed. You can't see the lumens.
Right.
Right, so they're inside the capillary loops. So they are endocapillary. So this is endocapillary proliferation. Right?
Right.
If this were lupus, this would be proliferative. A proliferative finding. This would be a sign of activity. Okay, so endocapillary proliferation right here. We're seeing that, and it looks to be a mixture of cells. It's hard to make out at this magnification. But nonetheless, we have endocapillary proliferation. Now, you're mentioning the capillary loop thickness. Where are we really interested in looking at capillary loop thickness? What disease? We really are. You have thick capillary loops.
Diabetes.
Patient usually has diabetes, heavy proteinuria. It's not in a non-diabetic. What would we What else would we think about with these thickened loops?
Deposition diseases can cause it.
Yeah, like a membranous.
Membrane.
A membranous would be kind of the most common thing. Diabetes certainly you do develop capillary loop thickening or thickening of the GBM. In these cases, they do look a little bit on the thick side, but it doesn't really fit with the clinical presentation, doesn't really fit at all with a membranous.
Right.
And there's no history of diabetes, and this doesn't really look like diabetes. But maybe there is some sort of increased material in those glomerular-based membranes. We'll have to see. All right, but the main finding here is a proliferative glomerulonephritis. It's endocapillary proliferation.
All right, I'll give you an H&E, which kind of demonstrates this just a little differently. You can see the cells a little better.
All right.
So this is H&E stain, and again I'm looking at the glomerulus. The capillary loops appear closed,
Right.
and the similar cells that we saw in the previous slide. There are numerous cells in the capillary lumen.
We have some cells that see this one as a
Neutrophil.
polymorphonuclear appearance, right? So this is a neutrophil. We do have occasional neutrophils in here too. We start seeing a lot of neutrophils.
Infection-associated GN.
Exactly, does rise on the list, and that seems like a possibility here
Yeah,
with
the
his
patient
history
had
of infection.
And a low C3.
A low C3, so there are some hints that perhaps there's some infectious possibility going on. All right?
Joe, can I just ask a question? I'm looking at the picture here at like the 1 to 2 o'clock area where you see that proliferation and that red stuff. Is that red cells? That's not fibrin, right?
Right. This is just appears to be some congestion.
Okay.
Right here in these capillary loops.
Okay.
Exactly.
All right. So let's go into IF.
All right.
We don't need to spend a ton of time on it, but I think because there's
So-
actually quite a few IF pictures we want to look at. But this is a C1q stain.
All right.
A C1q stain appears positive.
Positive, exactly. So bright green is positive. Negative, it's essentially black or nothing. But it's staining the capillary loops predominantly and some mesangial areas. But we're seeing it pretty much throughout these two glomeruli.
Okay. Here's C3.
C3 is also brightly positive.
Same thing, brightly positive in the glomeruli.
Okay. IgG.
Positive too.
Also positive.
Yeah. IgM is weakly positive. But
Positive, it's not
still
quite as strong, but it is still positive.
Okay.
Kappa positive.
Kappa positive
And
and lambda positive. All right, so we have a
full
lot
house
of things staining. Now, full house technically is with IgA as well. So we have an almost full house.
yeah, I didn't include
We have
IgA, but
two pair.
Yeah, 2 pair. So not quite full
That's
house,
okay.
but 2 pairs are pretty good. hands
Essentially,
still. Yeah.
it's a lot of things staining. So IgG, IgM, C3, C1q, Kappa, and then of course it's polytypic. It's Kappa and lambda, light chain staining as well. Okay.
So I'll ask Karthik, like, what disease do you normally see full house staining in?
Lupus is the most common.
Okay. Yeah. Which was low on our differential.
Right.
And if this was, we didn't see crescents to suggest vasculitis, but if we did see crescents, this would not be consistent with a posse-immune vasculitis because it should be posse-immune. Likewise, it's not consistent with an anti-GBM disease, which should have the linear IgG. So there's a little bit of unusual findings from the immunofluorescence based on our initial clinical diagnosis. So let's move on to EM and see if we can figure out what's going on.
So
All right.
I would like to orient myself first. The
Always a
one
good
that
idea.
I'm seeing in the middle is the glomerular basement membrane,
Right here. Yeah.
and
There's our GBM.
one below it is the podocyte.
Right.
So that would be the urinary
And
space.
start to make out a few foot processes here. So urinary space on this side.
And
And then in here, somewhere is a capillary loop, but it looks maybe on this side, looks like we're real close to an area of mesangium since this is so much more matrix in here.
Right.
All right, so what do we see? What is
So
this?
Those
I'm
are
highlighting with the arrow.
electron dense deposits.
Exactly. So we have electron dense deposits right here in this area that appears to be in the mesangium in this field, and here's some more down here at the lower right. Okay, let's keep going.
The glomerular basement membrane is again in the middle of the screen, and to
Right.
the right I see an RBC, so that's
So
probably
here's-
the
Let's outline that for everybody. This big dark blob here on the right side of the screen, that's a red blood cell.
And
Okay.
So that side is the blood side, and again I see similar electron dense deposits.
Right, here they are.
More in the
So how would you label these? Subepithelial, subendothelial, intermembranous, or mesangial?
mesangial and some subendothelial.
Exactly. So now we see the red blood cell. You
Right.
can even see this kind of looks like a lace-like reticular is how we pathologists would describe that sort of network right here of these right underneath the
Base.
well, it's sort of underneath this cytoplasm, which is from an endothelial cell. And you see this. It's almost like, we're always looking at three-dimensional structures in two dimensions, so you're kind of cutting it at a different angle. But these are those endothelial fenestrae that are kind of cut in a strange view. That's what we're seeing there. So we are in a subendothelial location. This is just organelles and cytoplasm from the endothelial cells. And then we have these subendothelial deposits right here, which really don't have an apparent substructure. All right, podocyte out here.
Okay.
Okay. Last EM picture.
Okay.
Again,
So-
the GBM is in the middle, and the one to the top of the screen would be the blood side, and the one
Right, so
below
this
would
is
be
blood. Or this is Bowman's space right here, and this is the blood, as you were talking about. There's another red blood cell up here. Okay.
the.
So at this power, what are we seeing inside that capillary loop?
Is it a thrombus?
Well, these have nuclei, right?
Right. So they're inflammatory cells.
They're cells. Yes, it's a mixture of cells, endothelial cells. It's hard to make out some of this at this power, but maybe I don't see a good polymorph nucleus, but undoubtedly that's what we saw in light microscopy. There's rare ones in there. So this highlights that endocapillary proliferation that we saw in light microscopy. This is what it looks like on electron microscopy. And again, out here, the podocytes. Here's our podocyte out here. We can see the foot processes don't look too happy, right?
Right.
They're
More
effaced
flattened out.
in this area. Yeah, they're completely effaced right here. Then over here we start to see a few that are somewhat more intact. See a little bit of microvillus transformation of the podocyte cytoplasm here. Both these things are signs of injury to the podocytes, which can happen with a variety of causes. In this case, it's this proliferative glomerulonephritis with these immune complex deposits that's leading to this. Now, some things we're not seeing are subepithelial hump-shaped deposits
Right.
that you would expect to see in infection-related glomerulonephritis. It's really subendothelial and mesangial, but it corresponds to what we were seeing on
Light
immunofluorescence
right.
with the electron-dense deposits, and yes, the light microscopy with the proliferation. So, putting this together,
Yeah,
What
that's our last slide. So this is it's kind of a head scratcher. I don't know what you guys think when we get this.
so Karthik, what do you think based on what we have now?
So based on what we have so far, it's proliferative glomerulonephritis with low C3 and positive immunofluorescence for most of the stains.
Right. So it's an immune complex mediated glomerulonephritis.
Right.
Right? That's basically what we have. It's difficult to go anything more specific. I mean, if the patient had symptoms and lab values that were in keeping with lupus, it would be consistent with that, but we
Right.
don't have that. It's really at this point, we don't have anything to suggest on our electron microscopy. It doesn't look like an infection-related glomerulonephritis. You shouldn't see all these subendothelial
Right.
deposits. We didn't see any cryoglobulin deposits or anything like that. I don't remember if cryo was tested for or not, but it's really looks like an immune complex mediated glomerulonephritis. Unclear etiology at this point.
Yeah, and so that's kind of how we took it as well. It was difficult to call this lupus nephritis without a diagnosis of lupus negative ANA. Really no symptoms of lupus for this gentleman, unusual age, presentation, and so forth. So we kind of were stuck calling this, immune complex mediated GN, which is not as satisfying as
No.
as making the diagnosis of ANCA vasculitis or something. And just to show that we weren't being selective with our slides, the final biopsy didn't show any crescents. Really, no chronic disease. Only 2 of 45 glomeruli were globally sclerosed. There was no chronic tubular interstitial fibrosis, and there were, as you mentioned, there were some focal areas of tubular injury. And so this made treatment kind of difficult. He had an immune complex mediated GN, and how do you treat that? So we made the decision to just give him prednisone, not pulse solumedrol, but just start him on a mg per kg of prednisone, because obviously we were dealing with something that appeared to be immune complex mediated. Obviously we made sure he didn't have any other infections. He actually got a bronchoscopy. He got antifungal testing, make sure he didn't have something that wasn't just showing up on the original cultures, all of which came back negative. And so we finally just made a decision, let's give this guy prednisone because his creatinine was worsening in front of our eyes. And so here's a slide showing kind of what happened. He got the biopsy on day 2. His creatinine continued to kind of trend up over the weekend. We were waiting for the results, and then Joe called us on Monday and said, he's got what looks like an MPGN pattern. Later on that day, it came back full house. The next morning, we saw the EM, and we said, look, this guy's kind of verging on dialysis. We finally decided just to give him the mg per kg of prednisone. And you can see he had a pretty dramatic response. So he got better immediately, never required dialysis. Within 2 days of starting the prednisone, his urine output picked up, his creatinine started to trend down. And as of follow-up, which was just a few weeks ago, he was down to prednisone 10 milligrams a day with his creatinine back to its baseline, which is a good outcome. So it's a nice case because not everything falls into this nice textbook, of the diagnosis that you want it to do, and this is an example of that. So, anything else to say about that, Joe? I mean, it was kind of a head scratcher. Is this something that's commonly, encountered in pathology where you can't, make the diagnosis and you just have to leave it as immune complex GN?
Not very often.
Okay.
Normally, there are other clinical findings. There's something else going on that we can pin it on a more specific etiology.
Yeah.
But every once in a while, it's rare, but we do see these where, unfortunately, we have to render a little bit more of a descriptive.
Yeah.
Diagnosis.
Yeah, and because everything looked so much like lupus on the kidney biopsy, I didn't show you the results, but we did send off things like antihistone antibodies because he was on an antiarrhythmic medication. It wasn't amiodarone, which usually causes lupus, but he was on this mixilotine, which isn't really associated with lupus-like syndromes, but we said maybe it's a lupus-like.
Well, that's
syndrome.
true. A drug-induced lupus, that does happen,
Right.
and but it didn't sound like there was any smoking gun there either.
Right.
It would have been nice if there was a drug that you could have removed and everything went away, but.
Right. But anyways, I thought it was a neat case. I hope you guys enjoyed it. Thanks for watching. I want to thank Dr. Gaut and Karthik for helping us out. You can follow us on YouTube at Wash Nephrology. Follow me on Twitter at Maximal_change. And we'll see you guys next time for the next recording. Thanks a lot.
Thank you.
Thank you.